Good morning, everyone. Thank you for coming. My name is Sophia Ahmed, and I'm delighted to be your host today for our Alberta SPORE Unit Capacity Development Platform presentation. This is the first in a series of our workshop to enhance equity, diversity, and inclusion within healthcare research and patient-oriented research that is occurring not only in Alberta, but beyond our borders. Okay, now I'm just trying to forward here. Excuse me for a moment. So just before we start, we'd like to take this opportunity to acknowledge that the University of Alberta and the University of Calgary are located on the territories of the people of Treaty 6 and Treaty 7, and we respect the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. Just in terms of, these are some housekeeping issues. The presenter portion of this workshop will be recorded. The recording may be shared, published, and or repurposed for other educational purposes. But it's important to note that the discussion portion of this workshop will not be recorded, and we'll just talk about how this is definitely a safe space for discussion in a little bit. It's important to note that images or screen captures of the workshop may be taken and displayed on our official Alberta SPORE Unit channels for engagement, promotional purposes, etc. If you do not wish to be part of in these images, please make sure that your video camera is off. And if you wish, please change your name so that that isn't displayed as well. Just a few housekeeping. If you wouldn't mind taking the pre-webinar survey linked in the chat, you will be asked to do a post-webinar one as well. This may be this is being recorded, and it's important to note that for educational purposes, this work may be published. Once again, presentations recorded, discussion portion is not. If you wish, please feel free to include your pronouns in your name, just part of the discussion, but do not feel pressured to do that. And again, just going back to the safe space for dialogue, everyone can read this just as well as I, but basically we will be using, it's a safe place. Please feel free to express yourself as you wish. We will use what we call but the Chatham House rules. So, you know, everybody is welcome to discuss outside after this presentation, you know, what in general terms was discussed, but we ask that no particular comment is attributed to a particular person or group of people. The rules for discussion, please assume positive intent. We're all here to learn. We're all doing our best, and we want to improve what we know. And it's important to recognize that we have a diversity of experiences, abilities, knowledge. You know, we want to practice active listening. I mean, I'm not here to tell anybody what to do. I think everybody knows all this already. But just at the end of the day, we'll all be good people. And here's Alberta SPORE Unit team. Oh, okay, that's me. So I'm the capacity development lead, and I am truly delighted to work with Kelly Buckrice, who is our associate director, and Amanda Wagner, who's the program coordinator. And a huge thank you goes out to Amanda for pulling this all together and the huge organization that went behind this. So I am truly delighted to introduce our speakers, whom I will introduce in greater detail just prior to each person's presentation, Dr. Shannon Riziki, Dr. Bukola Salami, and Dr. Paul Ferry. I also would like to take the opportunity to introduce our patient partners, and I apologize, there we go. So to start off with, and we will meet all of these people in greater detail in our breakout rooms. So in no particular order, Roo Afsa Khan graduated from Windsor University School of Medicine in the West Indies with an MD in 2013 and holds a bachelor's in economics and statistics. For the last 4 years, while preparing, Roo has been consulting and mentoring international medical graduates for the MCCQE Part 1. Prior to that, Roo was part of the pilot project for the PACER program, and during that had an opportunity as a patient representative at the Strategic Cardiovascular Network of Alberta. During that time, Roo participated in a cancer research study collecting data for the CBCF project. So now just moving on to Serene Banerjee. Soon after her family moved to Canada, Serene's husband was diagnosed with terminal cancer and passed away 9 months later. As a newcomer to the country, Wellspring Calgary became her asylum and inspired her to take an active role in patient wellness and advocacy. As a patient and community engagement researcher, she has participated in the South using a top-down approach within the South Asian community by inviting religious leaders and influencers to share information with cancer patients on end-of-life decision-making. Currently, Serene is helping the Diabetes, Obesity, and Nutrition Strategic Clinical Network to raise awareness of foot and eye health clinics among vulnerable populations. So thank you very much, Serene. I'm sorry, I'm just, there we go. Atorban Godlu is an internationally trained medical doctor and an active member of the Alberta International Medical Graduates Association COVID-19 Health and Wellness Team. He works as a case investigator at Alberta Health Services and is completing a master's program in health services management at the University of Lethbridge. Atorban has been a patient partner on several research projects and is currently engaged in a study identifying mental well-being needs in multiracial and ethnic minority communities during and post-COVID outbreaks, and a project looking at perspectives of vaccines in pregnancy. He is actively involved with the Eritrean Canadian community in Calgary. And then certainly, so thank you very much, Atu. And then last but not least, Louise Crane. So thank you, Louise. Louise has osteoarthritis and has worked with the Canadian Arthritis Patient Alliance for many years. The connection has enabled her to learn more about the disease and advocate for better understanding from the patient's point of view. She assisted in the development of a communication tool with the Arthritis Society of Canada on how to talk to your doctor. So we are truly delighted to welcome all of our speakers and our patient partners. And you don't want to listen to me talk anymore. So just to get going, the overall objectives of this session, I think you knew this when you registered, but really we want to go through in the next 2 hours to explain the principles of EDI within the context of health research and how they're relevant to patient-oriented research. We want to describe how EDI can enhance our poor environments, poor meaning patient-oriented research, develop better quality and support health equity, truly to reflect the diversity of the Alberta population. We want to identify strategies, solutions for integrating EDI to enhance these environments, and identify and describe the research roles and appropriate strategies, mechanisms for engaging inclusive research teams in patient-oriented research. And we all have the ultimate goal of optimizing health outcomes for all Albertans. And that's why we're here today. So how are we going to do this? So I'm coming to the end of my talk, and we'll just be moderating for the rest of the time. We will have Dr. Riziki speak first on incorporating EDI into research. Dr. Salami will then talk about EDI considerations in working with immigrant and ethnically diverse populations. And then Dr. Ferry will talk about patient partnership in health research. After that time, we will then move into our breakout room discussions. You have all been pre-assigned a room, so you will magically move into a smaller group where there is a case presentation, which you would have received before. And we had just some opportunities for discussion. At the end of that 20 minutes, everyone will come back to the greater room, and each breakout room will be asked to tell the rest of the group what you discussed and what you learned, or what other questions you have. So if I can ask everybody, and I'll remind you, just prior to the breakout rooms, if you can have a scribe within each of the breakout rooms who is willing to then speak to the broader group afterwards. And that is the end of my talk, so I will stop sharing. And I will take this opportunity to introduce Dr. Shannon Riziki, who is a very dear colleague of mine. So I'm delighted to have her as part of today's talk. Dr. Shannon Riziki is a general internist and a clinical assistant professor at the University of Calgary, who studies equity, diversity, and inclusion in the medical workforce. And I can say that Dr. Riziki's work has ultimately resulted in real change at the University of Calgary. And the University of Calgary Department of Medicine is being used as a model worldwide for effective interventions that do optimize outcomes, not just for the workforce, but then ultimately translate into optimization of health outcomes. So without further ado, I will hand over the mic to Dr. Riziki. Welcome.
Thank you. That's a nice introduction. I really appreciate it. This is my son, Clark. He's a little fussy, so I'm just going to hold him, but hopefully he will cooperate. So I'm going to discuss how to incorporate equity, diversity, and inclusion into your research. You're okay, hon. These are my learning objectives. Oh, thanks. So when we get our research training, we learn some foundational skills to help us design our projects. So we learn a little bit of statistics, we learn about study design, we get some training in ethics. And I would argue that one of the foundational skills of research is principles of equity, diversity, and inclusion. And I think this is a big gap in our training right now. And I'll show how these foundational skills can influence your research. So what does research look like when you don't understand principles of EDI? This article was published in Clinical Vascular Surgery last summer. And their methods were 3 men screening the social media profiles of their colleagues and rating them as professional or unprofessional. And potentially unprofessional content included things like pictures with alcohol or inappropriate attire, which would have been things like bikinis or provocative Halloween costumes, posting of political statements like gun control or abortion access. And this publication of this article led to a massive uproar. So basically 3 men scrolling their colleagues' Facebook pages and calling their Halloween costumes unprofessional. So eventually this article was actually retracted based on a lack of understanding of how equity, diversity, and inclusion may interact with professionalism. And a more subtle example is this paper published earlier this year. This is a study done in Johns Hopkins with gastroenterology patients, where the researchers compared the abilities of nurse practitioners and gastroenterologists in performing colonoscopies, with the idea that if nurse practitioners had similar skills to gastroenterologists, this may improve access to care and reduce costs for patients. However, in the study population, nearly 3/4 of the participants were Black. And this raised red flags for readers because Black patients accounted only for 30% of the patients in this clinic. This is especially problematic because Black people in the US have higher rates of colorectal cancer and greater mortality rates from that colorectal cancer. So therefore, you would presume that they should have the best care and maybe not participate in a non-inferiority study looking at whether someone who is has less experience, less training, and lower costs is non-inferior to a professional. This study ultimately found that there was no difference in the quality or safety of nurse practitioner scopes versus MD scopes, but that was not known when the study was started. And so there's a big question here is why were there more of these marginalized patients included in a non-inferiority study when those patients have worse outcomes? And an even more subtle but important example is the Made It 2 trial, which was published in New England Journal in 2002. So this is a study looking at implantable cardiac devices. So these are devices that go in the chest wall and deliver shocks to the heart when they detect an unstable heart rhythm. And this study demonstrated that those devices were associated with greater survival in people with a certain type of heart failure. And based on this data, the ICDs, or implantable cardiac devices, are recommended for all patients with this certain type of heart failure. But when you look at the study demographics, 85% of the nearly 1,200 patients in the study were men. In 2018, follow-up studies in registry data started to show that women had a lower mortality benefit, and they received fewer appropriate shocks than men who had these devices. But their risk of side effects, which in this case were inappropriate shocks, are the same. So women receive less benefit and more side effects from these devices. And despite these data coming out, this hasn't been incorporated into the most recent guidelines. So overall, what we can see is if we're not looking at equity, diversity, and inclusion in our research study design, at best, your research could be embarrassing and a waste of your time. And at worst, it could be harmful to patients. So what are these principles that we need to know? So I've listed several of them here, but there are undoubtedly more. So we need to understand what is marginalization and privilege and how does that interact with our studies? What is the history of our field and how can we acknowledge that appropriately? How do we meaningfully partner with communities and avoid tokenistic representation? How do we build capacity for research within marginalized communities, and how important is it to compensate them appropriately? How to disseminate results to these communities? Who owns the data that you generate? And how to use respectful and accurate language. So I'll start with marginalization and privilege because I think this is really critical. A thorough understanding of what is privilege is mandatory for all researchers. So privilege is created by systems of inequality in our society. So social structures like ableism and racism ascribe unearned advantage to certain groups and unearned disadvantage to other groups. And researchers must understand how marginalized populations may experience the clinical and research studies. So for example, in the study I talked about with the nurse practitioners and gastroenterologists, why were 75% of participants who were recruited Black in that study when we see that Black patients are excluded from other types of trials and studies? And I wonder if there were aspects of marginalization and privilege that were interacting in that recruitment setting that were not considered by the researchers. And I want you guys to note that having privilege in some aspects of your identity does not mean that you don't experience marginalization in other aspects of your identity. And so we need to look at people as a whole. And I've put a link in the top corner through a QR code to really delve into this topic. Something that I think is critically important is to understand and acknowledge the history of your field of study. And this is important in both your research design and in education. So an example is this is James Marion Sims, and he's considered the father of modern gynecology. He founded the American Gynecologic Society, which still exists today, and he invented the speculum. But how did he achieve all of this greatness? Well, he performed surgical experiments on enslaved Black women in the US without anesthesia, though it was widely available at the time, and without their consent. And after 4 years of experimenting, he perfected a method to repair fistulas. That's an abnormal connection between the vagina and other organs that can result from childbirth. And after he perfected this technique, he then began performing these surgeries on white women with anesthesia. So when we teach gynecology or the research and surgery to medical students and we don't mention this history, we're whitewashing and erasing the history of gynecology. And this upholds a fairy tale that medicine and academia are somehow above discrimination and bias, and it blinds us to looking for these issues in our own projects. So when we don't acknowledge that these things can happen, then we're not on the lookout for them, and you might end up having a study where you recruit only marginalized patients in a non-inferiority study. And I also think that mentioning this in lectures and in your teaching, so whatever your field of study is, looking for these types of historical issues makes people aware to look for them in themselves. It's, I think, very important. So what does it mean to meaningfully partner with communities? There's guidelines and things about community-based participatory action research and guidelines into how you can delve into this. And unfortunately, we don't always have time to go into this in great detail. But the main point here is that sometimes you don't get to do the research question that you originally intended to do. So when you go to meaningfully partner with a community and you bring them your research question, your study design, you may end up finding out that they have different questions or different methods that they prefer. And so you need to be open to coming to a community with the idea of them as equal collaborators and not a top-down approach. We all have heard that in academia and in the research pipeline, there are groups that are underrepresented. And so when you're building your research team or you're looking for collaborators, we often end up reproducing the same homogeneous group of skills. So we know that there's a paucity of Indigenous researchers, Black researchers, LGBTQ community members. And so how do we support that pipeline? And I think it's really important, no matter what your research field is to think about how you can build EDI into your research team. And that can help you avoid some of the issues that I brought up in those first 3 studies, is just having a diverse group of people on the team. So ways that you can do that are looking at professional societies or medical societies for people from marginalized groups. So I put up 2 examples here: the Black Medical Students Association in Calgary and the Canadian Association of Physicians with Disabilities. So you can just contact these organizations and say, hey, I'm looking for a study team member or collaborator. Can you look at your networks and see who might be interested? You may end up going even to like high school associations just to get that research capacity. And remember that these people, they're marginalized. They may not have the research background and skills that somebody who grew up with a PhD academic research or parent. And so you may have to spend extra time building that capacity and teaching those skills. But I think that's an obligation we have to the research community and to our patients to build up those skills. When you are teaching people or building up research skills in someone from a marginalized group, you must compensate them appropriately. So a lot of summer studentships are for less than minimum wage or underfunded. And remember that it's a privilege to be able to work for free. Some people don't have that privilege, especially people from lower socioeconomic statuses. So when you're doing your grant applications or you're building your project budgets, please consider that you may need to provide extra funding and justify extra funding to have team members from those communities that are traditionally underrepresented. And I think it's very important and very justified. These 2 principles are kind of related. So once you have results about a marginalized community, you need to disseminate those results in a way that that community can use to advocate for themselves or that they can understand well. And you need to consider data ownership. So you can't just fly into a community, do a big study and say, hey, Indigenous patients have worse surgical outcomes, publish your paper, collect your merit increase and go live your life. You have a duty to help that community understand what those results mean for them and to work with them to advocate for support or work with other scientists to address those concerns. And that might mean helping them write an advocacy report after you've published your results, or writing a letter to government, or whatever type of advocacy role that they need. Data ownership is complex. So if you're doing like interview data or collecting samples from a group, you need to understand that you can't just take things from these marginalized communities. And understanding the history of science really helps you understand why this perpetuates racism and supremacy in science. The First Nations OCAP principles, you can take courses in them. They're specific to First Nations group, but the principles of ownership, control, access, and possession of materials can be applied to other groups. And I really want to delve in a little bit to respectful and accurate language and why that matters. And this is probably one of the most actionable things that's easiest for you to do and take away to your own research today. So if you're not using accurate language to capture your demographics, then the results that you are reporting could be influenced. And if you're not using respectful language, then you're perpetuating bias and discrimination. So we know that respectful language reduces stigma experienced by patients. So an example that I'm going to use here, but can apply to any type of research, is when we're asking about sex and gender. So this is the wrong way to collect those data. So first, you have to understand what is sex and what is gender. So sex are the so-called biologic attributes, and we typically assign those as male and female, but it's incorrect to only list those 2 options. So we know that there are intersex individuals or people with diverse sexual differences that make up 1 to 2% of the population. So when you put just female and male, you are perpetuating a false binary of sex that we know is biologically not true. And you're inappropriately classifying or even excluding from your experiments 1 to 2% of the population, which when you're thinking of effect size, I think is really important. Also, it's legally incorrect. So in Canada, we have 3 legal sexes or genders: male, female, and X, which are allowed on your official documentation. So it's inaccurate. When you're asking about gender, you want to be sure that you're doing this correctly. So I've put this incorrectly here, but I will give you an example of the correct way, or a correct way that you could do this. So women and men are genders, and it's not correct to have a third option that's just other, like a grab bag. And the reason is that when you say other, you're saying that anybody who identifies as something beyond man or woman is somehow in this catch-all category that is different or wrong. And we know that gender is a spectrum. And so instead of using the term other, you can say a gender not listed. Probably the most accurate way to collect data about gender is just an open text field where people can self-identify, but it can make it difficult to analyze your data. So if you need categorical data, listing at minimum woman, man, a non-binary gender, and a gender not listed would be the absolute minimum. And again, I've put a resource up at the top about this. And the last thing I want to touch on is knowledge translation of EDI-based research. So we may have all heard that saying that it takes about 17 years for research to become a common practice, but this is not adequate. And it's definitely not adequate when it comes to when you find harassment, discrimination, and bias in your data. I think EDI-based research has a unique requirement for us to turn our findings into action, especially if you're from a privileged group. And this knowledge translation is advocacy. So if you turn up a difference in outcomes between Indigenous and non-Indigenous participants in your study, you must work to eliminate that difference. And what are some ways that you can do this? It's a bit different than what we learn about science, but you can start by solving a problem for your leadership. So rather than just going to a major society, a medical society, or to a paper and saying, hey, I found this difference, come up with a solution. You can say things like, we need a guideline statement saying that there may be a difference between men and women or males and females in this application of results, or saying we may need specific pathways for Indigenous participants in this field. So come with a solution. When you start with low cost or free initiatives, you can gather momentum for including EDI. So for example, if you're advocating to a journal or editorial board that they need to use patient-centered, person-first, and inclusive language, that it's free to do, it's simple to put those guidelines in, but it can make a big difference. Or you can, if you're organizing a conference, you can say, we're gonna ban manels, all male panels, and we're gonna think about how we can have a diverse set of presenters. So those things are low cost or free, but they can create that culture that's needed to incorporate this into all of academia and medicine. When you have local data, I think it really lights a fire under people. So a lot of the time when we present these types of issues, people will say, well, that's not an issue here, or we don't have that problem in Canada. But when you can say, actually, I studied this in our data, or I looked at this in our setting, and it is a big problem here, I think it can really create that motivation for change. And you have to know the literature of this area really well. You want to be an expert. When you're an expert, you want to speak about this as much as you can. You want to build that reputation for yourself and create that reputation as a problem solver in this area. You need to get a seat at the table where you can affect change. And so this can be uncomfortable if you're a scientist and you're not used to being on a lot of committees, but any table that you're at or any committee that you're participating in can be an opportunity to network with change makers who can help create the change we need. When you have a seat at the table, you should use that seat and you should speak up when you see something inequitable happening. And when you have that skill, you build your expertise and you build that reputation. And then listening to those groups, listening to those community members, and seeing how you can help them and how you can amplify their voices when you have these opportunities. And so EDI is a big area, and there's a lot of changing terminology, and there's a lot of ways that this can overlap or apply to your research. So I've provided some resources here on how you can build these skills and expertise among yourselves, how you can speak up, how you can be an ally. And so hopefully there are things here that you can apply to your own research. And I'm very happy to take any questions. I wasn't looking at the chat, but I will now if you have any questions.
Thank you so much, Dr. Riziki. This is Sophia talking again. I think we have time for maybe one question, if anybody has any. that
And you can put questions
burning.
in the
I haven't
chat.
been looking at the chat.
And I will answer your questions by typing too, so I don't take up all of your guys' time.
Okay. Perhaps just in the interest of time, I will move on to Dr. Salami's talk. I do encourage people to put their questions in the chat, and please feel free to direct message if you would prefer to remain anonymous. Feel free to direct message me. I can ask on your behalf, or certainly one of the presenters themselves. So thank you very much, Dr. Salami, for putting up your slides. So I have the pleasure of introducing our next speaker, Dr. Bukola Salami, who is an associate professor in the Faculty of Nursing at the University of Alberta. Her research program focuses on policies and practices shaping migrants' health. She has been involved in approximately 60 funded research projects and is actually the lead of approximately 20 of these projects with funding from national and international agencies. So is an incredibly internationally recognized expert in this particular area. She founded and leads an African migrant child research network of 30 scholars from 4 continents. So just giving an example of the reach of Dr. Salami's work. In 2020, she founded the Black Youth Mentorship and Leadership Program at the University of Alberta. And also in 2020, she was the recipient of the Sigma Theta Tau International Honor Society International Nurse Researcher Hall of Fame, the highest research award in nursing. So we are truly delighted to welcome Dr. Salami today. And without further ado, I'll pass the mic to you. Thank you. I think you might be muted, Dr. Salami.
Yes, I am muted. Thank you so much for the opportunity to be here and to present today. And it's such also a great pleasure to speak right after the previous speaker because I would be moving from what she talked about to focus much more on immigrant population. And I'll be providing some examples that would actually shed more light on some of the points that she has raised. So here is an agenda. I will talk about, I will just give an introduction, just one slide. And then I will talk about Canada's history of racism. And I will give 2 research examples. So examples of research that I have done with the immigrant population and how some of the principles related to equity, diversity, and inclusion were incorporated in those research. So my research program focuses on, seeks to address the decline in immigrant health by focusing on the health of the most vulnerable groups of migrants. Over the last 7 years, I've been involved in around 60 funded research projects. So in terms of Canada's history of racism, a lot of people, when they think about Canada, they think about the multiculturalism policy in Canada. Yes, we do have a multiculturalism policy, but we do have also a long history of racism in Canada. So for example, in 2010, there was a policy that was implemented to prohibit for stated grounds landing in Canada of any race deemed unsuitable for the climate or requirement of Canada. And this was a policy that was implemented to basically try as much as possible to ban especially Black and South Asian immigrants from being able to migrate to Canada. We also have, of course, Canada's long history of racism towards the Indigenous people. And this is a quote from the Truth and Reconciliation Commission. The very first paragraph of the introduction section. And it says, for over a century, the central goals of Canada's Aboriginal policy were to eliminate Aboriginal government, ignore Aboriginal rights, terminate the treaties, and through a process of assimilation, cause Aboriginal people to seek to exist in Canada as a distinct legal, social, cultural, religious, and racial entity. And of course, this all led to cultural genocide. We also have reports that have been created in 2017 of United Nations Working Group of Experts on people of African descent, which actually identified as Canada's history of enslavement, racial segregation, and marginalization of African Canadians has left a legacy of anti-Black racism and had deleterious impact on people of African descent, which must be addressed in partnership with the affected communities. And a lot of this, we can think, oh, this happened, several years ago, but it continues to have an impact and an effect until today. So for example, one impact is when we think about the current situation related to COVID-19 vaccine, that we know that Black population have the lowest rate of COVID-19 vaccination. And one of the reasons for that is actually very much linked to research that has been done on Black population in the past. So we know history, for example, of the syphilis study that was done on some Black population, where data was collected from individuals with syphilis, but they weren't told that they were being participating in research or that they actually had syphilis. And a lot of people, still actually refer to that study that was done years ago in terms of their willingness to take vaccine, COVID-19 vaccine. So that's one of the ways that these historical issues that have happened in the past do continue to haunt us in Canada. So I'll give an example of a participatory action research project that I did with African, Black, and Caribbean youths in Alberta. And I would say probably I should change it to Black because collectively the youths wanted to be identified as Black. Initially, in my research, I wanted to focus on African population, but they were quick to say they really wanted, because of the group that they were in, they really wanted a collective identity of being Black. So we met with 8 Black youths of the Yakima group. At that time, I was a board member of Africa Center. And at the time, I had heard that the youths were struggling with, creating programs and, responding to the needs of their peers. So I met with them to discuss how can I be of help was my questions. And there were about 8 youths in the room, and they identified that they wanted a research study that focused on mental health. That they wanted a participatory approach, and they told me straight off that they don't want to be involved. They want to participate, they want to lead, they want to contribute. That they wanted an intersectionality perspective that is also attentive to issues related to gender, they wanted a focus on African, Black, and Caribbean, and they wanted a need to build capacity, and they were willing to contribute to the study. So this other research question is not as much important for the study, but we were looking at mental health needs and access issues within this population and what potential exists to mobilize the community. We did interviews with 30 youths, and we also did 4 conversation cafes. And conversation cafes were an open forum for dialogue and exchange of ideas. In the first conversation cafes, the youths wanted, based on the interviews that were done, wanted a cafe focused on health promotion. In the second conversation cafe, the youths wanted one that was focused on basically how to deal with your parent 101, intergenerational relationship. In the third conversation cafe, the youth wanted something about intersectionality. And with a focus on intersectionality, they really, really wanted integration of LGBTQ2+ into the project. So for the conversation cafe, we had a panel of 3 members. 2 were from the LGBT community. 1 was a Black LGBTQ, 1 was a non-Black LGBTQ, and 1 was not connected to the LGBTQ community. They also wanted a session on policy and program intervention. And for the policy and program intervention, they took participants through imagining what a health center for Black people will look like. Well, luckily, that actually materialized. And what they discussed during that meeting actually led to the establishment of a health center, a mental health clinic for Black people in the province of Alberta, in Edmonton, Alberta. It was implemented by Africa Center, and the group was a youth group of Africa Center. So I had 10 youth participated as an advisory committee member, in the first meeting, they told me that they also wanted to collect their data themselves. And the way I did this was to ask them who wants to be involved in data collection. 7 of them wanted to be involved in data collection. They were hired as research assistants and paid as research assistants. And they collected the data. And my research assistant, who was not a youth, but also Black, collected about half. And the youth collected about the other half of the project. Now, one of the things in terms of considering EDI is who do you collaborate with? What is the composition? And the composition of the group, because a lot of those in the Yakama group were female or non-binary, it also reflected the composition of the advisory committee members. And we met 3 times throughout the research project as a team, as a general team, but we also had about 6 smaller meetings as smaller group meetings to inform the process. So they provided advice on data collection procedures, including how to deliver conversation cafe, advice on knowledge translation and dissemination. They interviewed some participants. They organized and they led conversation cafes. So I felt like throughout this, I felt like my role was actually more of a mentor. That they, it shifted, from they actually did a lot of the data collection. They developed the initial conversation cafe guide. They facilitated participant recruitment. They analyzed the data. Their co-authors and they've led some of the presentations in the past. Their co-authors on all publications. So we engaged in capacity building. So we provided a 4-hour training on qualitative research and research ethics with practice session on how to conduct interviews. They completed the research ethics module. A couple attended the 1-day training on how to use qualitative software for data analysis. And they had close mentorship of 2 senior doctoral students, as well as me, and at least 1 meeting with project lead before each conversation cafe, and provided examples capitalize on strengths. And there's also importance in terms of patience and encouragement. So some of the challenges is issues related to power relations, and especially power relations, not just because I'm a member of the community, but power relations along lines of class, and also especially power relations along the lines of age. And I think what helped with the power relations was actually the 2 doctoral students who were able to actually help in terms of building that. Time, there was a need for flexibility. And there was also a need in terms of reconciling gaps between academic priorities and community priorities. So our focus when we finished was not publish, publish, publish. Our focus was translate, translate, translate. So the mental health clinic was created before we were able to have a publication out. So we don't yet have a paper published. We just had a paper accepted by the Journal of the Public Health Agency of Canada. But we had our report out first, and the results of this was actually also presented to the Prime Minister of Canada at a meeting I had. Funding priority, limitations and priorities, and confidentiality and data security was an issue, especially because it's a small group, and how do we get 7 people involved? And what we did is we trained just 2 of the youths to have access to all the data. So the youths, when they collected data, they only had access to the data that they collected. And only 1 or 2 of the youths actually had access to all the data altogether. Selecting important social locations to consider, and selecting priorities in data analysis based on intersectionality lens, and also diversifying a sample. So where you recruit from actually shapes who is going to participate in your study, And as the previous presenter said, if you want to recruit a diverse population as research assistants, then consider, for example, engaging with Black Medical Student Association if you wanted to have more Black population. For this, because a lot of the sample of those in the group were female, we had a lot of people from more representation of that group. Some of the rewards and success, we recruited more participants than we had planned. We had reached data. We youth-led and delivered conversation cafe. We had a capacity building and learning experience and data and future projects to address youth mental health. And it was also personally fulfilling experience for me as I saw the youth group. So I maybe let me know when I am what you call it, when I'm above the time limit. There's another project that I did on parenting and mental health promotion practice of African immigrants. And I did this study much earlier, I think in 2016 and 2017. So for this study, we sought to examine the parenting and mental health promotion practice of African immigrants. So this study will basically provide more insight into strategies in terms of working with the immigrant population. When we had applied for this project, we said we are going to do a critical ethnography, but I'm not sure at the end what to call this project, if it was truly a critical ethnography or it was really a community-based participatory action research that we end up doing. But you'll decide at the end of the presentation what it was. So we interviewed 14 African immigrant community leaders, and we interviewed 32 African immigrant parents. We interviewed 12 service providers, and we also did 2 focus groups with diverse service provider. And before we had our interview, we had a advisory committee set up that advised us throughout all stages of the research process. At the end of the project, we held the Stakeholder Engagement Day that was attended by about 150 diverse stakeholders. And that led to the Stakeholder Engagement Day led to the implementation of a knowledge, they called it a knowledge, implementation committee was what the participant wanted to call it. And based on that, some of the recommendations of the implementation committee has actually been implemented now, including the mentorship program for Black youth, and also the creation of a resource tool for Black parents in Alberta, for African parents. So some of the lessons learned in terms of recruitment is engagement with the community is crucial. And one of the lessons is also the need to hire multiple community workers with extensive knowledge. So if you want to hire, recruit immigrant population, now if you only recruit one community worker, they'll probably only recruit people that are very similar to them. A way for you to diversify your sample is recruit multiple community workers, even if they're only recruiting a small amount, each person recruited a small amount, because then you'll be able to have a more diverse sample. We found that recruitment at ethnic grocery stores worked for us, but of course you want to have limitations on this if your focus of your research was on food. Whether or not people are eating African food, but African grocery stores work for us in this case. Personalized emails for recruitment, mass emails, I found never works. And honestly, emails don't work as better as a phone call. Mass email and newspaper. I have tried in the past recruiting through newspaper advertisement for immigrant population, and it never really works for me. Maybe I get 1 or 2 people. It's not cost effective, but it helps your community to stay informed, to know that you're still doing your study, if that's what you want. Ensure vibrant advisory committee, excellent insight, extensive community networks, and knowledge of the community. Be flexible with time. So, we were prepared to wait at the door or make repeated visits. So there were times when I went for interviews and it happened to be a Muslim prayer time. So, I just have to wait. Or there were times when there was 1 or 2 interviews where, the interview took longer than planned and I had to take a break for her to finish praying, and then we continue the interview after. Use rapport, refer to existing networks or relationships, and carefully share positionality. Attend to gender relations, and for this research project, we did we were looking at parenting practices, and parenting practices is very much gendered, very much along the gender lines. So a lot of the interviews I ended up doing, but I had a male that did some of the interviews with men, but a lot of the interviews I ended up doing. You also should be careful too, because oftentimes people will say, I need, someone that speaks Arabic. You're from Arabic, you're from Syria, and you speak Arabic, you're from Sudan. But there are different types of Arabic too, so you have to be aware of that. And what I've also learned in some of my interviews is the complexities related to communities that have been exploited in the past and communities that have been traumatized in the past. So sometimes, you may have the example that one of my participants gave in an interview once about interpreter service is that you have one person from the Pashto tribe in Afghanistan and you have one person from Taliban tribe. And sometimes they don't want to talk to each other because of the past experience related to trauma. Attend to Muslim prayer time, working around issues of literacy. In the past, I have provided oral consent, and I've used oral consent sometimes when I am working with, so I've done some research in the past with undocumented migrants. And for those groups, they definitely usually don't want to sign anything or put their name on paper anywhere. So I have used oral consent for some of those. Provide interpretation services, use of interpreter versus translation. So interpreter services, which is basically word of mouth, I find is much cheaper. Translation services, probably will cost around $90, $50 to $90, $50 to $100. Translation services tend to cost between $1,000 to $3,000. So that makes it much more complex. Clarity of information in recruitment letter and flyers. I remember when I was a doctoral student, I was doing a study, and sorry, I think I'm running too late. Just tell me when to stop. I was doing a study about Philippine educated nurses. And I was at the University of Toronto then, and I put it in a newspaper. And I said, invitation to participate in a study. Well, many of the people that were contacting me because they were internationally educated. I was from University of Toronto, and I said invitation to participate in a study. They actually thought it was to come and complete an educational session, to complete a program of study. So I had to change that to research because of that.
Yeah, you're hitting your mark.
Okay, I'll be prepared to issues of language and interpretation. Capitalize on strengths and attend to ethnically important moments. So some of the ethical dilemmas is who else should participate in the interview, balancing ethics and respect, and resolving contradictory stories. Attend to issues related to positionality. So in my doctoral research, I talked about one in terms of, participants always asking me, so why are you interested in us? And really, the need to engage and reflexively engage. And also be attentive to participant perspective on their own identities rather than the identity that you put on participants. And participants are school researchers. And knowledge translation, disseminating to affected community, community engagement, and also reciprocity is important. And I think that's about it. Sorry, I rushed through the final slides. Sorry about that.
It's all good. That was amazing. Thank you very much, Dr. Salami. That was, I actually have a lot of questions for you, which I'll hold for myself. But just in the interest of time, Dr. Ferry, if I could ask you to put up your slides. And just while you're doing that, I'll take the opportunity to introduce. So Dr. Paul Ferry is the Associate Director of the Alberta SPORE Patient Engagement Platform and a Senior Research Associate in the Department of Community Health Sciences at the University of Calgary. Dr. Ferry also hosts PEP Talks, which is the Patient Engagement Podcast, where he talks to everyone involved in health research to explore their perspectives and experiences. And so beautifully positioned in order to speak to us about this today. So thank you very much, Dr. Ferry. Take it away.
Thanks so much. So I'm here just to briefly talk a little bit about patient partnership and health research and some considerations that you might want to think about when engaging in this sort of work. So today I just want to briefly help define what we mean when we talk about patient engagement in health research, what we mean even by the word patient, and then just sort of think out loud for a few minutes about some considerations about the intersection between equity, diversity, and inclusion and patient partnership in health research. And then I actually want to turn over the floor to four community members who have partnered with our team on various projects to share their perspectives on patient partnership and health research. So when we talk about patient engagement directly from the CIHR patient engagement framework, it's an approach to health research that involves meaningful and active collaboration in all parts of your research project, from higher level governance and priority setting to conducting the actual research. Some great examples from the two presenters before me, and all the way through to knowledge translation and publishing and sharing the results of the work. And depending on the context of the project, it needn't just involve engaging individuals on a one-to-one relationship. It can also involve engaging communities, as Dr. Salami so nicely examined for us in her presentation. So why talk about patient engagement? It is one of the main approaches to patient-oriented research, not just for CIHR and SPORE, but just sort of overall in that practice. So patient-oriented research can be research that engages patients as partners, which includes communities. It can focus on patient-identified priorities or anything that improves patient outcomes. So really, here we are talking about patient engagement. So the real key about patient engagement, just as the term goes, is that it's about engaging community members and communities and patient research partners as members of the research team. So they're not engaged as participants in studies. So participants in studies are obviously very important for all sorts of reasons. But when we talk about patient engagement in health research, it's not about survey recruitment. It's not about trial recruitment. It's about adding different perspectives to your research team by engaging patients meaningfully as partners. So it's really important there to separate it from the concept of patient participants in health studies. So really, again, patient research partners should be thought of as equal and active members of your research team. And I mean, sometimes people will raise an eyebrow. I mean, probably less so if you've come to this this webinar here, but sometimes people think, oh, how can that work? But it's best thought of as when you're putting together a research team, what do you want on your research team? You want a diversity of experiences and skills and backgrounds. Similarly, as you want a data scientist or an epidemiologist or a methodologist or a clinician, you will also want the perspectives of the lived experience that patient partners and patient research partners bring. So it's really important when thinking about it, especially in an EDI context, to consider what we mean by the word patient. So it's really not just according to federal or provincial strategies, but even what people mean when they talk about patient engagement. Patients are really a diverse group unto themselves. It can mean sort of current and former patients, like the direct recipients of care, but the perspective of community and patient partners also does involve caregivers, family members, and as well as a sort of more collective voices. So patient support groups, lots of patient advocacy groups exist, all sorts of organizations like that. Community groups. We worked on projects as part of this patient engagement team, working directly with nonprofit organizations or sort of grassroots community groups. As well, it can even just mean members of the public at large, depending on the sort of the context of your project. So a question that we do often get as part of our work really strikes, I think, at the heart, sometimes even quite accidentally, about questions around EDI. So that people ask, how many patient partners do you need to engage in your project? So really, I mean, the frustrating answer for some is just that there's not really an ideal number here. It's not about finding 7 people to meet a protocol that you've written. It's really about thinking about the specific context of your project, and it's not about just having one patient partner on your project to say, yes, I have a patient partner, and that we've completed patient engagement and I've ticked off the box on a CAHR application. It's about thoughtful engagement with the community. So we do generally recommend, for instance, to involve as many patient partners as possible to diversify that the perspectives on your research team. So you want to thoughtfully consider how to have patient research partners be integrated with your team, and the questions of equity, diversity, and inclusion really must be a very central consideration to all of the activities here. So, for example, we can think of some of these considerations as my last point here. So there are lots of, for example, barriers to participation, both for the patient research partners as you're doing this sort of work, but also for participants in your study if you also have them. But for patient research partners, you might want to think about technology barriers. For example, if you live in a rural area, you might have slower broadband, so over-relying on video Zoom meetings might prevent meaningful participation. We worked with a researcher who was working with unhoused populations, and to overcome, even in the age of COVID, to overcome the need to meet virtually, one member of the research team would provide technology access to people without technology access there. Language barriers, we've talked about a little bit already, but researchers using things like the AHS language line. Time can be a barrier to participation. And not to spoil too much of the fun for the case study, but for example, if you only have meetings during the day, you can imagine excluding all sorts of people from partnering and participating in your projects. Also, some thought needs to be given to the questions of bias in recruitment methods. So lots of researchers will use essentially convenience samples, putting up a poster by a clinic that you work near. Might be okay, depending on exactly how you've done it, but ultimately, I mean, so my PhD work was not in health, and it was a social science PhD, but we learned, like, one of my favorite things to read about was always how the diversity of social networks. So social networks, not so much like Twitter or Facebook, but the people that you know tend to be, and this is my favorite word, homophilous, which is basically just homogenous. So you don't want to just rely on convenience approaches for recruitment. And finally, my last point here is just that individual and community approaches can also be important. So there can be individual one-on-one relationships with patient partners, but depending on the context and the project, it may also be necessary to sort of go beyond or move away from that and engage directly with larger communities. And I think none of my examples will be as good as Dr. Salami's. So I'll encourage you to reflect on all of those. my little plug, if there's 20 seconds for an ad, that if you want to think alongside with us about patient partnership and equity, diversity, and inclusion, you can contact us through the apps4u.ca website there, and you can email us here at this sort of group Gmail, so we can all see it. So I'm gonna stop sharing my screen actually at this moment. And then I know that we have invited some of our patient partners that we work with on projects, and I was wondering if they wanted to share their perspectives on these issues. So maybe I'll call on Atto if you're there.
Hi everyone. Thank you so much for having me and for the opportunity to speak today. So a little bit I would like to share from my experience that I have been involved directly and indirectly in research. One is the cancer screening from the AHS. I was directly involved with that. I was called by AHS to help recruiting people and to translating the people. So I recruited 5 people, and we set up a convenient time for the researchers, and I am as a patient partner, which I didn't know that time. I was just helping, but now I really understand that what patient partner mean. So it was a 90-minute like Zoom meeting, and the people like that I recruited, they feel more confident and comfortable to share their ideas and the thoughts regarding that research. And overall, I think the feedback from AHS was it was great. So the people were from Northeast, where most of the immigrants reside there. And like Dr. Powell mentioned, it's like the technology, language barrier, and cultural very restricted, and knowledge in all the limitations in here. So involving patient partners or advisory communities really helps as a bridging to make it like easier, like as EDI, equity, diversity, and inclusion is everything like that. So I think patient partners play a vital role in that. And the other thing is recently I'm involved in research with Dr. Trin from the University of Calgary about the mental well-being during and post-COVID-19 pandemic. And that one is what the research was designed. It was like there were international medical graduates, I think 5 of us, who speaks different languages. And we try to reach out communities that we are actively participating with, and we can recruit people and doing the questionnaires by phone, emails, and in person if possible. And that would also help to have a diversity and representation of all, not all, but mostly of the community, and that could also help to reduce the bias, at least, and including and representing all the communities. I think that because of the time limit, that's the 2 things I would like to share now, and thank you so much again.
Thanks so much, Atto. Maybe Rue could go next.
I was going through Dr. Salami's lecture and also Dr. Sophia and I was just listening to you and Atto as well. And I would like to say that although you said that the media is not that powerful, but my research projects while I was with PACER but my experience has been that it is the most powerful media, because they cover the South Asian communities, and I will believe that any communities which has diverse language issues, if we use their media, we use their radios, we can reach them more immediately than anything, than sending them emails, because there are a lot of people in the diverse communities, they don't know how to use the software. They don't know how to use the Zoom. They don't know how to use the Microsoft Teams. They're still learning how to use their phones, let alone getting on the computer and be in front of the, front of the computer and try to be online with the rest of the teams. So it's important that we have to understand that the media is a very powerful tool, especially so for our research projects, and we recruited more than 35 people. For my first project as a pilot, for our second project, same thing, we used the same medias. And I was writing down the notes about the confidentiality of the data and Dr. Salami and the ethics part of it, competencies. I have lots to say about those things because I also speak 5 different languages. I roam around the communities and I understand the different communities and I do interpretations. And especially with the IMGs, when I work with them, I understand their issues. Ethics is a huge, huge thing. Our understanding of ethics is different. As IMGs, our understanding of ethics is different. As Canadian doctors, our understanding of ethics is different. It all comes down to quality. Because even if, let's say that Dr. Sophia, let's say that if you see an MRI, if you give it to 5 different MRI radiologists to look at it, interventional radiologists to look at that MRI, every 5 of them, all those 5 of them will have a different understanding of that MRI. So they will write down different notes. So similarly with the ethics part of it, when we are looking at that part, we are trying to integrate the competency and we are trying to integrate the diversity. We have to understand that we need to have quality in those things. And with the focus groups, we can, same thing, same focus groups, we can have 10 focus groups. But unless we reflect on those focus groups that this is what we have, and we go back to those focus groups, their understanding will change totally different. So if as a patient and as a physician, I look at both the spectrum. From the patient point of view, I am looking at my understanding. That when somebody gives me a question and when somebody gives me a document, which I cannot even read and understand the language, how am I going to sign it? Of course, I'm not going to sign it. I'm going to be very cautious. So these are the dilemmas, absolutely, that we need to address.
Thanks so much. So we have 5 more minutes. So maybe I see Serene.
Yes. Hi, thank you so much. I wanted to add that when Rue and I did our focus groups together, there was a lot of food. Rue didn't tell you that she organized literally a banquet for the group. And for our South Asian communities, food is a very, very, very big hub. And it just opens you up completely. There's a family warmth that comes through that. So I'd just like to point that out. I was asked I wanted to do something back for Wellspring Calgary because I had been a beneficiary at a time when my social network here was zero. That place really became a hub for me. And every time I entered the doors of Wellspring Calgary, my fears and tensions and everything about my husband's slow passing just disappeared. So I wanted other people who didn't know about it to benefit. And so one of the challenges that we had, because the facility is in a very beautiful part of Northwest Calgary, and most of the immigrant population lives in the deep Northeast. So to transport them to here for the experience, because the experience is everything, was a big challenge, and many of them didn't have transport, and I was in no way able to arrange for people to come there at that time. I am now, but I wasn't equipped at that time to even think that way. So what we did is we collected heads of institutions. And I love going to them because they bring all their social networks, they bring their parish, they bring all their connections. And while publicly people may not know who has cancer, the priest might, or a person of good standing becomes a confidant. And so they are in a position to then, after they've experienced Wellspring, at the appropriate time, bring the right people there for the programs, for the beautiful programs that they do. So even though in that scenario, which is different to a study, we didn't quite have the big majority and the big banquet that we wanted, we did have very select and very important people who to this day continue to refer people within their communities to the programs over there.
I didn't want you to bring in the food, the Serene, because,
but it was so important.
Because I wanted to keep it simple. But since you mentioned it,
no, but you took a lot of trouble. You took a lot of trouble to do it. It wasn't just, just food.
Another thing for the social media, for our research projects, what we did was we went to the temples. We went to the religious places directly.
Exactly.
So it all needed an announcement because it's a the priest or the parisher is like Serene said, it's an understanding. So of course, even people who did not or could not read and write, because literacy is an issue between the communities, and especially if we are most of the problems with the patients start when they are elderly and when they are of certain age. It doesn't begin with the young people. So that is why most of our patients are elderly. So if they can listen to the parisher, it's easier to engage them. Mm-hmm. But most of these patients are not literate either. So that's one of the literacy is a huge issue.
Thanks so much for sharing. I just want to make sure that we have a few minutes for Louise to share with us as well.
Thank you. I'm a former nurse practitioner, and I found that patients are scared in the Aboriginal community to see medical professionals due to historical and current racism and bigotry. An example of treatment of injuries, dentistry, and even childbirth without medication, because they understood that Aboriginals had a high tolerance of pain. And that is not true. Many of our communities have been researched to death, as the patients have quite often told me. And if there's true engagement with patients from the Aboriginal community and research process, there has to be a lot of patience, education for all people involved. So one great example is Dr. Cheryl Barnaby did research with some of her students at Siksika, and we had a group of people in Siksika that had arthritis at various ages, but mainly seniors. And the participants communicated such positive things about their experience, about how they were fed, bringing the food back into it. They were fed really well. We had it over lunchtime. And the fact that experience, they were heard. The patients were actually heard. The patients got involved in the organization. And when the patients organized different workshops and education experiences, it has gone on to build further trust in Dr. Barnaby and the arthritis clinic that she operates at Siksika. And it had huge impact in that area. So I just wanted to share that quickly with you.
Thanks so much, Louise. I know that Dr. Barnaby's work is really amazing, and if you're not familiar with it, I'd recommend seeking it out. So with that, I'm happy to turn over our time now.
Great. Okay. Well, thank you very much, both Paul and to our patient partners. That was absolutely amazing. And I think it really resonates with all of us when you hear these personal stories. And I shouldn't say personal stories, but stories of this is what we did and this is what happened. And so I really want to thank everyone for bringing those experiences and sharing them with the group. So now we actually, and I want to thank all of our presenters. I don't know if anybody, going back to the question, the comment I should say about media, this is not exactly what we were talking about, but if anybody, I forgot to mention this at the beginning. So Twitter is like going crazy all over this workshop, which is absolutely amazing. And if you are so inclined, please feel free to tweet about what we're talking about today. Please tag at Alberta Spore Unit Capacity Development, if you don't mind, because I really want to emphasize that this is the beginning. We really want change to happen. And thank you for being here today, because you are at the beginning of change. So this is the beginning of a movement. So everything that each individual can do to make that change or contribute to that change is amazing. So with that, I'm delighted to say that now we are going to break into our breakout rooms. And Amanda, I think maybe I should turn it over to you. Basically, what's going to happen right now is everyone has received this case study. This is meant to be a discussion starter. If you find your breakout room kind of veers off on something different, particularly in light of the incredible presentations we've just had, feel free. That's absolutely fine. So Amanda, I'm going to turn it over to you. And I just ask that each person in each breakout room has, I say a scribe, but someone who's willing to then be the spokesperson for that room. Just maybe assign that person at the beginning. Oh, here we go, the breakout room. So Amanda, what's going to happen next?
So I'm just creating the breakout rooms right now. So just give me a moment. I did put the case study as well in the chat if anyone needs to download it so you can have a copy of it. So if you want to take a minute to read that while I finish assigning the rooms, that would be great. So, and take maybe a minute break to refresh some drinks or anything and come back in a minute.
Okay, so we'll just take a minute break right now for those who need it or who would like to have it. And but please don't go away. This has been absolutely fantastic. And I don't know if anybody has any questions that they'd like to even bring up for the group right now. Some things that I have really taken away are the importance of not having tokenism and some really important ways to incorporate people with lived experience as part of an equal partner as part of the research team. I don't know if anybody else wants to put in the chat or verbally say things that that have impacted them. I don't want to take over. I could talk all day.